Hello and welcome to Pathology Scuba, where we dive into disease pathogenesis. I'm Pratima Singh. I have chosen the subject of vasculitis to talk about due to popular request. So we're going to talk about the most common vasculitides today. In this video, I'm going to talk about various vasculitides manifestations and associations, and I'm going to take a bit of a lighthearted approach today because I'm going to use pop culture references to aid in recall of this topic. Disclaimer, I do want to make it very clear that these vasculitic conditions can be very debilitating for patients who are affected. It can lead to significant morbidity and mortality. So I do not want to make light of the topic. However, in terms of education, I wanted to put a digestible and memorable experience just to learn about these particular diseases. Again, the material in this lecture is for medical students, most ideally. This is not delivered at a level that would benefit people who don't have some pre-existing medical education, and it is not discussed in sufficient detail to aid practicing physicians. Today we're going to talk about vasculitis in terms of their classifications, and then we'll go into some case study of the following vasculitides. Utilizing the Chapel Hill nomenclature, you can see that there are three major categories: small vessel vasculitis, medium vessel vasculitis, and large vessel vasculitis. And within small vessel vasculitis, you can see that there are ANCA-associated vasculitides and immune complex-associated vasculitides. So what do we mean when we say something is ANCA-associated or immune complex-associated? Most vasculitides are, in fact, immune in nature. Now, this immune mechanism can either be because antibodies are interacting directly with cell surface antigens, like antigens that are on the surface of our neutrophils, ANCA, anti-neutrophilic cytoplasmic antibodies, or antigens that are present on our endothelial cells. So again, this is a direct damaging antibody. Now, in immune complex mediated tissue injury in vasculitis, this is resulting from circulating immune complexes that deposit along the vascular walls. And as they deposit, they will activate complement and generate a neutrophilic response, which will cause local tissue damage. So that's another mechanism by which vasculitis may occur. And if you don't know your ANCAs, it is definitely something that you need to be familiar with. Now, we used to call these C-ANCA and P-ANCA, and what they stand for is the cytoplasmic pattern or the perinuclear pattern you see on immunofluorescence. Now they have been named PR3-ANCA, or antiproteinase 3, or MPO-ANCA, or anti-myeloperoxidase, because these are more specifically talking about the antigen that is reacting in these particular ANCAs. So again, C ANCAs are now PR3 ANCAs, and P ANCAs are MPO ANCAs. So back into our vasculitis classification scheme, we again notice small, medium, and large categories. The reason why this is helpful is the caliber of the vessel involved will inform the manifestations caused by that vasculitis. This image is just to reinforce the notion that there would be obvious variable consequences if you are suffering an inflammatory condition affecting the large vessels, medium vessels, or small vessels. In the case of large vessel vasculitis, you may expect symptoms such as limb claudication, absent pulses, or bruits. So those are things you might want to look for in your patients, or if you're taking a test in the vignette that might indicate that you're dealing with a large vessel vasculitis. Take a look at the signs and symptoms of small vessel vasculitis, purpura, especially palpable purpura, so the purpura you can actually palpate. We have alveolar hemorrhage, of course, the small capillaries within the lungs, those are very small vessels. You can see splinter hemorrhages in the nail bed, so these are very small vessel manifestations. So now let's go ahead and start with some case studies. And the first patients we'll see will have large vessel vasculitides. And our first patient is going to be this lady, Blind Al. Blind Al is a 75-year-old woman. She has a history of stiff joints and hip pain, but now she has new symptoms of headaches and facial pain. She also experienced a little bit of weight loss and some significant fatigue, but she has a pretty difficult roommate she's dealing with, so her symptoms were blamed on that. Unfortunately, her symptoms progressed into acute blindness. I diagnosed Blind Al with giant cell arteritis. Giant cell arteritis is sometimes visible as a thickened temporal artery. Now, if you saw this on Blind Al, again, you might just think she's frustrated with her roommate, but it's actually that inflammatory and then eventually fibrosing scarring process that can thicken the temporal artery. Apart from the temporal artery, remember, the ophthalmic artery can also be involved, causing blindness. You can even have involvement of the vertebral artery. This is a microscopic depiction of what that inflammatory infiltrate looks like. You see that the wall of the vessel has inflammation in it, so much so that this elastin stain shows a disruption of the normal elastic layer that should be present within this arterial wall. Part of the inflammation includes giant cells, and so that is why it's called giant cell arteritis. We don't really know what causes giant cell arteritis, but we do know that it is a disease that is most typically seen in older patients. In fact, some criteria include that the age of the patient must be over 50. And you have to be aware of this as a possible condition because stroke and blindness are major complications, particularly if it is unrecognized and untreated. Let's talk really quickly about Blind Al, also indicating that she had stiff joints and hip pain. When you have a patient with giant cell arteritis and they talk about joint aches, especially morning stiffness, hip pain, you have to consider whether or not they have an associated condition called polymyalgia rheumatica. And I do believe Blind Al must have this as well. In fact, there is a spectrum of giant cell arteritis to polymyalgia rheumatica that indicate that they are likely extremely related disease processes. The next patient we're seeing in clinic is Toph Bei Fong. Toph is a Chinese girl from a small province in the Earth Kingdom, and she has blindness as well. She has high blood pressure. She's pretty worked up. When you examine her, she actually has weak radial and carotid pulses and in fact exhibits upper extremity weakness. Now, she didn't even realize that because she uses her lower body for most activities, but your physical examination does reveal upper extremity weakness. I diagnosed Toph Bei Fong with Takayasu arteritis. This is also a large vessel vasculitis by category, but it can also affect the medium vessels as well. It's going to have very similar histology to giant cell arteritis, but there are some differences. First of all, originally we thought it was more likely to occur in East Asian populations, but we now know that it's universal in occurrence. One demographic that is very different, though, is the age. Takayasu's arteritis tends to occur in much younger patients than giant cell arteritis, as you can see here. Takayasu's arteritis has a predilection for the aortic arch, and I'll show you an image in a moment that depicts that. Two stages of presentation are typical. In the first stage, there are very nonspecific symptoms like fatigue, weight loss, achiness. These could be present in a lot of vasculitic conditions. This could be present in a lot of autoimmune conditions. But then stage 2 tends to get a little bit more dramatic. Headaches, dizziness, visual changes that can progress to blindness. And Takayasu arteritis is sometimes called pulseless disease. That is one of the hallmarks of Takayasu arteritis. Other things like blindness, renal hypertension, and myocardial infarction can also occur. This arteriogram shows the presence of aortic arch involvement in Takayasu arteritis with the arrows showing stenosis of brachiocephalic, carotid, and subclavian arteries. With this image, you can readily identify why these patients might have claudication of their upper extremities and even pulselessness. So Toph Bei Fong, with her blindness, with her upper extremity weakness, she got an angiography just like the one I showed you, and it did allow for the diagnosis of Takayasu arteritis. Now we'll move into our medium vessel vasculitides and see some patients who have those conditions. The first patient we're going to see is Edward Cullen. Now, he's a 17, quote unquote, year-old man who has long-standing hepatitis B from a blood transfusion he received 100 years ago. And for those of you who recognize Edward Cullen from the Twilight series, he is, of course, a vampire. So that is a little bit of an inside joke if you have not seen or read the Twilight series. Edward Cullen is presenting with weight loss, hypertension, and numbness and tingling of the arms and legs. He's in so much pain. An examination you do shows that he has painful and bruised legs. I diagnosed Edward Cullen with having polyarteritis nodosa. Polyarteritis nodosa is a necrotizing vasculitis, and it involves small to medium-sized arteries, and it is typically seen in young to middle-aged adults, but you can see it at any age. There is a classic association where about 30% of patients with polyarteritis nodosa have hepatitis B, although that prevalence is shrinking somewhat. It's a little closer to 20% currently. And polyarteritis nodosa is an immune complex mediated vasculitis. So again, you would see antibody antigen complexes forming, planting on the endothelial surface, and then having local tissue damage from complement and neutrophilic response. This is an image of what you might see in polyarteritis nodosa, this transmural inflammation of the vessel wall. This hyper pink appearance does indicate that there is some necrosis as well. And as these walls weaken, aneurysms can occur. So poor Edward Cullen, he does have a biopsy performed and it shows fibrinoid necrosis of the vessel with thrombus formation. So he does have polyarteritis nodosa. The next patient we're seeing is Stewie Griffin. Little Stewie is brought in by his mother because he has a fever and he's had it for 2 days and his eyes are red, particularly his eye right here. When you examine him, he has swollen cervical lymph nodes. He actually has blisters on his oral mucosa and his tongue has a hyper red strawberry appearance. And then one day after his initial presentation, he develops a full body rash. I diagnosed Stewie Griffin with Kawasaki disease. Kawasaki disease is considered a medium vessel vasculitis. However, it can involve large, medium, and small vessels. We really don't know what causes it. One of the most interesting things about Kawasaki disease is that it does affect infants and small children. And on initial presentation, it doesn't have classic vasculitic presentations. It has more of a presentation that looks like a viral illness. Sometimes it's called mucocutaneous lymph node syndrome. So mucocutaneous lymph node. Mucous membranes include red eyes, dry mouth with blisters, cutaneous, red and peeling skin. And then lymph node, of course, refers to lymphadenopathy, particularly in the cervical chains. After this occurs, the residual vasculitis has serious sequelae, including coronary artery disease and cardiac valvular disease. If you recognize this syndrome early enough, you can do intravenous immunoglobulin or IVIG within 10 days, and you can avoid some of the more significant long-term consequences of this disease. These images show the physical manifestations of the mucocutaneous lymph node syndrome, including the conjunctivitis, including the mucosal membrane changes in the oral mucosa, the strawberry tongue. You can see the erythema, the rash, and you can even see the cervical lymphadenopathy, which of course would be easier to palpate. Again, the progression into vascular disease, particularly vascular disease that causes aneurysms, and this is classic, these aneurysms of the coronary arteries. We can fend this off if we recognize and give intravenous immunoglobulin. So Stewie Griffin did come to our clinic and was diagnosed with Kawasaki disease. His mom did bring him in, and he received his course of high-dose IVIG. He is not grateful. Now on to small vessel vasculitides. The first patient we're going to see is Walter White. Walter White is a 51-year-old man, and he has hemoptysis, so he's coughing up blood. We immediately do a CT scan of the chest, and we see large masses in both lungs. When we inquire, it turns out he's had chronic sinusitis and renal insufficiency. I diagnosed Walter White with granulomatosis with polyangiitis, also known as GPA, also known as Wegener's granulomatosis. The symptoms I mentioned, the sinusitis, the hemoptysis, the renal disease, all can occur in GPA, but of course we need to work up whether or not this is what's going on. And one thing we would definitely want to do is do an ANCA test, and specifically we would want to do the antiproteinase 3 test. It is an excellent marker for GPA. We might even say it's pretty specific for GPA. And if you thought that was painful, you know what else is painful? A cold sore or a canker. Remember, PR3 is also C-ANCA. And I guess I'll stop with the bad puns. And of course, if you biopsy the involved sites, you may get a little bit better information. Take a look at this gross image of a fixed lung showing multiple areas of involvement by Wegener's granulomatosis. You can see why this might be confused with a neoplastic process, but when you biopsy it, you don't see tumor. You see necrotizing granulomatous inflammation, and that's classic for GPA. Granulomata, vasculitis, and necrosis are the hallmarks of GPA. So Walter White has a diagnosis of granulomatosis with polyangiitis, which was greatly aided by the positive anti-PR3 test that we ordered. The next patient we're going to see is Darth Vader. And Darth Vader is a 57-year-old who's had long-standing asthma and allergic rhinitis. In fact, his breathing is pretty labored, but he says it's been like that for a long time. Now he begins to experience very painful tingling of the hand, he only has one, and his feet. I diagnosed Darth Vader with Sjögren-Strauss syndrome, also called eosinophilic GPA. The key with Sjögren-Strauss syndrome, or eosinophilic GPA, is the association with asthma and eosinophilia. These patients, once they develop vasculitis in this scenario, will have neuropathy, they may have lung infiltrates, they may have paranasal infiltrates, but if you do a biopsy, you can probably guess what you'll see. This is an example of Sjögren-Strauss syndrome, and if you look on high power, what you will see is the eosinophilic infiltrate with these inflammatory cells showing that bright red, even almost reddish orange appearance. These are the eosinophils that are the characteristic inflammatory infiltrate in Sjögren-Strauss syndrome. Sjögren-Strauss syndrome, or eosinophilic GPA, is also ANCA associated, but in this case, it's a myeloperoxidase antibody that is positive in Darth Vader. So that fits the diagnosis of Sjögren-Strauss syndrome. Our final case is actually a miscellaneous vasculitis. This is a 51-year-old monarch, and he has a heavy smoking history. He's presenting with pain and skin changes of the lower extremities, and when you examine him, you actually note that he has patchy necrosis of his lower digits. And this is an actual historical figure. This is George VI. George VI was diagnosed during his lifetime with Thromboangiitis obliterans. Thromboangiitis obliterans is also called Berger disease. This is where you have inflammatory thrombi in medium and small vessels that cause gangrenous and other ischemic and infarctive conditions. These patients tend to be younger adults, but they almost always have a heavy tobacco use history. Now, that's almost always smoking, but it does occur in other forms of um, smokeless tobacco. It can also occur in marijuana use as well. So, this disease should prompt asking the patient what type of smoking history or tobacco history they have. Of course, not all heavy smokers develop this disease, so you can imagine there is some linkage to particular HLA haplotypes that seem to predispose for development of this condition. When these patients have symptoms related to this disease, they can include Raynaud's phenomenon, claudication, ulceration, and gangrene. And again, this is all caused because of those areas of vascular occlusion. And one of the reasons it's so important to identify this disease and ask about smoking history is that if patients are in their early stage of disease, smoking cessation can actually reverse the disease course. And just some fun visuals showing you this combination of fibrin and inflammatory cells creating this inflammatory thrombus. This is characteristic of thromboangiitis obliterans, and you might think that there's similarity with this lit cigarette. And if you like comparative visuals, here is a picture of someone who has thromboangiitis obliterans with necrosis of their distal fingers. And I found this picture to sort of help underscore the contribution of smoking. So in a way, this has now become a history of medicine lecture because George VI did indeed have thromboangiitis obliterans. He had to have treatment for severe pain related to his disease. He had to have a lung excised. He actually had lung cancer. And of course, that's not because of this condition, but it is related again to his heavy smoking history. And his final death at the age of 57 was thought to be due to coronary thrombosis, which would certainly be attributable to TAO. So in summary, we've covered various vasculitides and we've talked about pop culture and historical references that hopefully help you remember details regarding all of these various diseases. Okay. So again, thank you so much for watching. If you haven't done so already, you could subscribe if you want to see more pathology randomness, assuming you love pathology, even a fraction of how much I love it. Share it around if you think other medical students would benefit from it. And if you've got some comments or ideas for future sessions, you've got my email. I've been Pratima Singh. Thank you so much.